Today I will be speaking about the clinical management of verapamil and propranolol overdoses. In order to fully understand this type of overdose, we must first look at each drug on its own. First, we will speak about verapamil. Verapamil is a calcium channel blocker. Calcium channel blockers are utilized for a variety of different reasons. Verapamil can be used to treat angina as well as arrhythmias, including PSVT, AFib, and aflutter. Verapamil is also a common antihypertensive prescribed to patients to control their blood pressure. Verapamil may also be used for prophylaxis treatment of cluster headaches. Doses for verapamil range depending on what the medication is used for. Verapamil comes in different formulations such as immediate release, sustained release, and controlled release. It's important for a paramedic to be aware of these variations, as clinical presentation and toxicity timeline may vary. Now let's get into the mechanism of action for calcium channel blockers. Verapamil disrupts calcium movement through calcium channels all throughout the body. Calcium channels are located on myocardial cells, pacemaker cells, vascular smooth muscle, and pancreatic cells. Let's first look at myocardial cells. In order to understand this fully, let's reference the cardiac myocyte action potential picture. Calcium enters the cell at phase 2. This initiates calcium release from the sarcoplasmic reticulum, which ultimately leads to a muscle contraction. If a patient takes a calcium channel blocker, it would disrupt the flow of calcium and thus decrease contraction. Therefore, calcium channel blockers' effect on myocardial cells is decreased contraction. Now let's look at pacemaker cells. And in order to understand these fully, let's reference the pacemaker action potential picture. Calcium channels open at phase 0, which causes calcium to enter the cell. This is what generates an action potential needed for the propagation of the impulse responsible for our heartbeat. If a patient takes a calcium channel blocker, it would reduce the amount of calcium entering the cell. This reduction means it will take longer for enough calcium to enter the cell and cause an action potential. This would prolong phase 0. By prolonging phase 0, the distance between the two peaks in the picture will get further apart, which represents a decrease in heart rate. Therefore, a calcium channel blocker's effect on pacemaker cells is decreased heart rate. Next, we have vascular smooth muscle. Calcium is what maintains muscle tone, and when a patient takes calcium channel blocker, there is a reduced amount of calcium present to cause contractions, resulting in decreased vascular muscle tone. Lastly, there are calcium channels on our pancreatic cells. Calcium normally plays a role in triggering the release of insulin. If a patient takes a calcium channel blocker, the release of insulin can be hindered. Now let's look at propranolol. Propranolol is a non-selective beta blocker. Beta blockers are utilized for a variety of different reasons, including the treatment of angina, as well as arrhythmias, including AFib and aflutter. Propranolol is also used as an antihypertensive in some patients. Propranolol may be used for non-cardiac related conditions such as migraines and tremors. Propranolol is even growing in popularity as a medication for situational anxiety, such as public speaking. Doses for propranolol vary from small doses for anxiety to the larger doses required for arrhythmias. Let's look at how propranolol works. In order to cover the mechanism of action for beta blockers, let's review beta receptors. Beta receptors are a type of adrenergic receptor, and they are used to carry out the functions of the adrenergic nervous system. There are three different types of beta receptors: beta 1, beta 2, and beta 3. Beta 1 receptors are mainly located in the heart and have a positive chronotropic and positive inotropic effect. When they are activated, a series of events occur which ultimately leads to an increased level of calcium. And as we just reviewed, increased calcium means increased cardiac contraction and heart rate. Beta 2 receptors are located on smooth muscle, and stimulation of these receptors cause muscle relaxation. This relaxation causes vasodilation towards skeletal muscles, kidneys, heart, and liver, which ultimately increases perfusion to those same areas. Beta 2 receptors also cause bronchodilation and GIGU and uterine relaxation. Beta 3 receptors are related to lipolysis, but that's not really applicable to our subject content today. So now that we've reviewed the normal function, let's discuss beta blocker usage. Essentially, if a patient is using a beta blocker, the medication would fill the beta receptor and block anything else from stimulating that receptor. By blocking this receptor, the medication is effectively also blocking any sort of beta response as well. This is known as an antagonistic effect. By blocking these receptors, we will actually get the opposite effect. Let's refer to the chart on this slide. Normally, beta receptor stimulation in the heart would cause a positive inotrope and a positive chronotropic effect. However, when a patient is taking a beta blocker, the medication blocks this from happening, resulting in a negative inotropic and a negative chronotropic effect. This applies for everything on this chart. Normally, beta stimulation would cause bronchodilation. However, with a beta blocker, as you see, the opposite effect is noted, bronchoconstriction. The other effects of beta blockers include muscle constriction for GIGU, which basically means a increased GIGU motility, and we'll also see hypoglycemia as a beta blocker potentially as an effect. If a patient were to experience an overdose on both verapamil and propranolol, there is a potential for catastrophic consequences. Severe poisonings are characterized specifically by profound bradycardia and hypotension. This is due to the synergistic effect of overdosing on both of these medications at the same time. Both of these medications, as we've discussed, cause a bradycardia and a hypotension, but they're both occur through different pathways. Therefore, with both of these medications combined, both pathways will be utilized and thus will have double or a synergized effect of bradycardia and hypotension. Further, calcium channel blockers and beta blockers both disrupt calcium flow to elicit their effects. So therefore, if we have overdosed on both these medications at the same time, there will be other synergistic effects due to both these medications trying to block calcium in some form or another. Therefore, taking all of this into account, calcium channel blockers and beta blocker overdoses have similar physiological and toxic effects. This means that treatment is nearly identical for both overdoses. However, it is important to note that one of the main differences being that calcium channel blocker toxicity is more often associated with significant hyperglycemia due to their effects on our pancreatic islet cells. However, aside from this small difference, it's very, very similar and the treatment is almost identical. A patient's clinical presentation may differ for various reasons, including time of ingestion, method of ingestion, how much did they ingest, etc. Common clinical manifestations of a calcium channel blocker and a beta blocker overdose include hypotension and bradycardia. These are our hallmark manifestations of severe toxicity. These are the presentation that we as paramedics are most concerned for, as they are usually the most difficult to manage in severe toxicity. Other clinical manifestations include an altered mental status due to decreased cardiac output. This decreased cardiac output can also cause dizziness, syncopal events, or even seizures due to that hypoperfusion to our brain. We might also get some nausea, and there may be arrhythmias that may also develop as a result. These may include heart blocks, bradycardias, and ventricular dysrhythmias. Physical examination of this patient. So physical examination for a patient with suspected calcium channel blocker and beta blocker toxicity is the same type of physical examination you would do on every single person that you would interact as a patient. So you want to check their level of consciousness, which may vary depending on the severity of toxicity. They may be alert and oriented, they may be altered, or they may be unconscious. You want to check their ABCDE as part of their physical examination and respond accordingly if you need to do any appropriate interventions. Some potential things to note there is you may have some airway difficulty if the patient is an asthmatic or has any other bronchospastic disorder and is also overdosing on a blocker. Disability, we might have a patient who has some deficits due to the hypoperfusion caused by beta blocker overdoses and calcium channel blocker overdoses. Head to toe exam. So in our head to toe exam, we might notice signs of poor perfusion like pale, cool, clammy skin. We're going to potentially have patients who are complaining of chest pain or feeling of discomfort. They might have dizziness or lightheadedness. As far as physical findings go, we're not going to see too many of that with this toxicity. And lastly, part of our physical examination is vital signs. So our vital signs, most common ones with these toxicities, as mentioned previously, is bradycardia and hypotension. When dealing with a calcium channel blocker and beta blocker overdose, there are some special considerations to keep in mind. So toxicological assessment. It's important to know the time of ingestion, the specific name or formulation of the medication, the number of pills ingested, and the dose of the pills ingested. It's also beneficial to know if there are any co-ingestants, such as other medications they may have taken for the day or any other poisons they may have ingested. Consult poison and drug information services. PADIS is a great resource to utilize, and they're the leading specialists and should be consulted whenever possible, even if the patient is asymptomatic. Psychological assessment. If this overdose was intentional overdose, or if it was the result of an abuse or neglect of a vulnerable patient, then a psychosocial assessment should occur. Was this a medication error, or was this a suicide attempt? Was the ingestion unintentional, or the act of a caregiver? Psychiatry, social work, or child services may need to be involved. Consider grapefruit consumption. Grapefruit is a well-documented inhibitor of CYP3A4, which is an enzyme that's actually used to metabolize verapamil and other drugs. So if a patient were to take their same normal dose of verapamil and follow it with the consumption of grapefruit, that may be enough to elicit an overdose. This is because verapamil goes through extensive first-pass metabolism, and only 20 to 35% of the drug actually reaches systemic circulation. If grapefruit inhibits this enzyme and inhibits the metabolism of verapamil, that means that there's going to be a huge increase in our verapamil serum levels, and there's going to be a lot more verapamil that reaches systemic circulation, making it easier to overdose. We also want to consider ETOH consumption, as it does have similar effects to grapefruit juice. Treatments. Treatment for this patient would include a standard approach and assessment. This means that the practitioner will assess LOC, ABC, and complete the appropriate interventions. If airway support is needed, suction and apply an adjunct. If breathing support is needed, begin assisted ventilation or oxygen therapy. And if circulatory support is needed, begin chest compressions. Once you've adequately managed the patient's LOC ABCs, now it's time to begin treatment for the overdose. As mentioned previously, treatment for calcium channel blocker and beta blocker overdoses are similar. Treatment is aimed at improving perfusion and reversing myocardial dysfunction. This is done through various treatments, including intravenous fluids and atropine, calcium gluconate, glucagon, vasopressors, phosphodiesterase inhibitors, high-dose insulin euglycemia therapy, and invasive procedures. Let's start with IV fluid boluses. It's standard practice to start with IV boluses for hypotensive patients anyways, so long as there's no contraindications. In mild cases, this may be all that's needed to reverse the toxicity. Atropine is also standard practice for bradycardia. Although efficacy is minimal and unlikely to improve this patient, it is still worth an attempt. Calcium. Calcium can be given in an attempt to raise calcium serum levels. The goal is to raise them high enough to a point where it overcomes the blockade effects of the calcium channel blockers, as well as the downstream effects of the beta blockers. Glucagon. Glucagon increases inotropy and chronotropy. It does so by increasing cyclic AMP and increasing the calcium level. Glucagon is a typical first-line medication for these overdoses. If the patient is hypotensive, refractory to glucagon, calcium, and IV therapy, vasopressors may be utilized if the patient is still hypotensive. Phosphodiesterase inhibitors may be utilized as well for their inotropic effects. These inotropic effects are caused by an increase in cyclic AMP through a different pathway than previously mentioned. It acts similar to glucagon, however, glucagon is preferred as it has inotropic effects and chronotropic effects. High dose insulin therapy may be administered, and this is due to increased inotropy. Usually, this is done if all other treatment modalities have not assisted. So, normally, cardiac cells acquire their energy via fatty acid oxidation, but glucose is needed in times of stress. During this overdose and during all this stress, the heart needs to utilize glucose. So when we provide insulin, it improves glucose utilization in the heart and it supports that heart and gives it that energy source that it needs. By doing so, we're actively preventing cardiogenic shock. Please note that that you must administer dextrose as well with insulin, though, if you're going to use this treatment modality. Lastly, invasive procedures may be used. So this is when all treatments have failed and the patient may even be in cardiac arrest. So the hospital may utilize an intra-aortic balloon pump or ECMO, depending on capabilities. They have been used with success. Transportation decisions. Let's go back there. So how do we make a transportation decision? Typically in school, we've learned that any complication to ABC, LOC, or any multi-system trauma is automatic, load and go, driving hot to the hospital. However, Lycus has identified 5 key questions to ask yourself when you're trying to make a transport decision. Is your patient going to die? Given the clinical presentation of your patient, you're likely going to drive hot for an unstable patient who's going to die and cold for a stable patient who's not going to die. Further, you're likely going to choose you're going to go to a close hospital if the patient is going to die immediately versus going to a specialized hospital if your patient is not going to die immediately. Next question, was your patient stable? How about now? If your patient went from being stable to suddenly becoming unstable, that's a sign that they're just decompensating. This would trigger a transportation decision of nearest possible hospital and likely driving with lights and sirens. Where are you going? Does this patient meet destination criteria for a particular hospital, or can it be the nearest hospital? Is your decision safe? Is your patient unstable? Is driving lights and sirens worth the risk? Is the route to the hospital you've selected a safe one? Is there any road hazards like ice or weather conditions? And lastly, what is the potential benefit? If transporting lights and sirens is worth the risk and provides greater benefit for the patient's outcome, then you may consider driving hot. By asking yourself these 5 questions, you'll be able to come up with a safe and appropriate transportation decision. Sue and Weiselberg have identified common pitfalls that healthcare practitioners face when managing calcium channel blocker and beta blocker overdoses. The first common pitfall is the patient looked great on arrival. I thought he would be okay without close supervision. These patients can look okay on presentation but deteriorate rapidly. They should be closely monitored as their initial clinical presentation may give you a false sense of security. Well, the patient only ingested 1 pill. With this class of medication, 1 pill is all that it may take to cause serious toxic effects. The patient may also be a chronic drinker or may have ingested grapefruit that day, further exacerbating the toxicity. The patient isn't even diabetic, so insulin should be withheld. As we've discussed in this presentation, insulin also has positive inotropic and chronotropic effects. It is not just used for diabetics. Well, we don't know what the formulation they took. He was asymptomatic, so I sent him home. If the formulation is unknown, assume the worst case scenario. Further, as previously discussed, patients may deteriorate rapidly. Just because they're asymptomatic initially does not mean they don't have the potential to deteriorate if, for example, it was a long release or an extended release tablet. So to review, let's take home and review these take-home points. Calcium channel blockers and beta blocker overdoses when severe are characterized by bradycardia and hypotension. So those are our 2 that we are most concerned of and the ones that are most deadly. Treatments are directed at correcting this hypotension and the myocardial dysfunction. Depending on various factors, clinical manifestation of toxicity may be delayed depending on the amount they've taken, the type, the formulation. These overdoses can also be accidental, such as mismanaging medication, consuming grapefruit juices, or they could be intentional, such as suicide and abuse situations. Thank you for taking the time to listen to my presentation today on the clinical management of verapamil and beta blocker overdoses. These are all the journals and resources that I have used to create this presentation. Feel free to pause this video here to review the references. I'd like to thank you once again for taking the time to review this presentation. Thank you and have a good one.